Hi everyone, today I'll be going over nonlinear pediatric and geriatric pharmacokinetics. So I'll first start with nonlinear pharmacokinetics. Nonlinear pharmacokinetics refers to saturable dose and concentration dependent processes where pharmacokinetic parameters may change as a function of dose, concentration, and time. Some factors causing nonlinearity include overdose, pharmacokinetics, drug-drug interactions, and autoinduction or auto-inhibition of metabolism, as well as many other factors that maybe Dr. Steinberg included in your lecture. It's important to know this figure here on the right as it demonstrates the different nonlinearities of pharmacokinetics. First, I'll go over nonlinear absorption. There are many factors that affect the rate and extent of bioavailability of oral drugs, including permeability across membranes, the rate of dissolution from the dosage form, as well as transporters. Some examples are listed here in the table below. So for amoxicillin and gabapentin, they experience carrier-mediated saturation at higher doses. Amoxicillin at higher doses has lower peaks in serum amoxicillin concentrations, which is caused by absorption saturation, and this extent of absorption changes demonstrates nonlinear pharmacokinetics. Similarly with gabapentin, it is also absorbed through carriers, and at higher doses, the amount absorbed does not increase linearly, thus also exhibiting nonlinear pharmacokinetics. Meanwhile, saturable first-pass metabolism through the liver with CYP450 enzymes can occur. For instance, nifedipine experiences saturable first-pass metabolism. Other processes that can lead to nonlinear PK include the pharmacologic effects of GI motility, like with erythromycin or chloroquine, saturable gastric absorption, like with penicillins or omeprazole, and circadian variation, like with valproic acid. Next, I'll go into nonlinear distribution, where transport into any secluded area in the body can be nonlinear depending on uptake kinetics, energy dependence, and receptors necessary for the drug to enter cells. Again, some examples are listed here on the slide in the table below. So like naproxen and valproic acid have saturable plasma protein binding. Naproxen is highly protein bound, but there are disproportionate changes in protein binding with increasing concentrations of naproxen. At higher doses, we see an increase in the number of free drug available, which can lead to toxic effects. Saturable protein binding is important for many other drugs as well, as albumin is known to bind tightly to acidic drugs. Another example of nonlinear distribution is with estradiol and mycophenolic acid. So estradiol has been shown to be stored in tissues due to its lipophilicity and released back slowly into the circulation, resulting in abnormal blood levels. Because of this storage effect, we see a change in the pharmacokinetic behavior from the first dose and the subsequent multiple dosing. For instance, after aggressive uptake of the first dose, the second dose peak is not as high. Meanwhile, with mycophenolic acid, there is a higher inter- and intra-individual variability in its pharmacokinetics. This is because once mycophenolic acid is absorbed into the systemic circulation, it's metabolized to its glucuronide metabolite that can be stored in the gallbladder and re-enter the GI tract, resulting in a secondary injection back into the systemic circulation and causing nonlinear pharmacokinetic distribution. Other examples include saturated tissue uptake or prolonged tissue binding with drugs like methotrexate, digoxin, amphotericin, cisplatin, prednisolone, paclitaxel, or imipramine. Other examples can also be found in your lecture slides that Dr. Steinberg reviewed. For nonlinear metabolism and elimination, there are many drugs that have this aspect, especially if they're eliminated with CYP450 enzymes, like with SSRIs. It tends to decrease with saturation and increases with induction of metabolism. Renal and biliary elimination saturation can also occur when the renal clearance decreases. And finally, nonlinear elimination does not follow first-order kinetics. Clearance and elimination half-life changes as a function of the dose and concentration, and AUC is not proportional to the amount of drug absorbed. Other examples of nonlinear metabolism and elimination include saturable active tubular secretion, saturable tubular absorption, changes in pH, urine pH, like with aspirin, where you can give bicarbonate to basify the urine during aspirin overdose and try to turn salicylate back into the body and into an ionized form and prevent reuptake. There's also biliary secretion and enterohepatic cycling, which increases the half-life. So Michaelis-Menten kinetics actually kind of refers to this general concept of nonlinearity, and it's the rate of reaction depends on the concentration of enzymes and substrate. So there's different parameters that are affected compared to like first-order pharmacokinetics, and can be seen here on this table. So Phenytoin is an example of nonlinear pharmacokinetics. I will go through the different parameters First is absorption. It's actually 100% absorbed, and it exists in different formulations: phenytoin acid and phenytoin sodium. Phenytoin is an anticonvulsant used to treat seizures, and is dosed between usually 200 to 400 milligrams per day. The steady-state plasma concentrations of phenytoin increases disproportionately with the rate of administration, and tends to have a therapeutic concentration between 10 to 20 milligrams per liter. It's also distributed. Its distribution is increased in patients with diminished plasma protein binding and is also affected by obesity. Phenytoin is highly protein bound, and displaced phenytoin re-equilibrates with tissues, resulting in a large decrease in total plasma concentration, and total levels will appear to be lower relative to its potential therapeutic effect. Protein binding is also affected by hypoalbuminemia, where the patient has low serum albumin, renal failure, where the free fraction increases to 0.2 to 0.3 due to the decrease in serum albumin, resulting in changes in binding affinity. When the creatinine clearance is above 25 mL per min, the binding affinity changes minimal. When it drops below 10 mL per min, the binding affinity changes significantly. It can also be affected by drug displacement, like with valproic acid, where when valproic acid concentration is increased over 20 milligrams per liter, phenytoin displacement from protein binding sites increase. It can also be affected by carbamazepine. Phenytoin also exhibits capacity-limited metabolism, which is characterized by mechanistic kinetics, and results in clearance values that are decreased with increasing plasma concentrations. And changes in the maintenance dose results in disproportionate changes in steady-state concentrations. It also exhibits saturable metabolism in its therapeutic range, as it's metabolized with CYP2C9 and CYP2C19. It should be noted that it's also affected by pharmacokinetics. So poor metabolizers, even if with a small change in dose, results in big changes in serum concentration. There are thus many drug-drug interactions that alter the PK of phenytoin, include enzyme induction with carbamazepine and phenobarbital, rifampin, which increases the Vmax, liver disease, which decreases the Vmax via decreasing in enzymes or activity, cimetidines, SSRIs, and amiodarone are its competitive inhibitors, and thereby increase Km. Next, I'll go over pediatric pharmacokinetics. So, as probably mentioned in lecture, children are not little adults, and to model PK behavior, you need to look at a variety of different factors. However, the goal is to reduce variability in dosing, whether it be weight-based or body surface area dosing, normalization to adults with allometric dosing, or using population PK models and Bayesian parameters. Some factors to consider in pediatric pharmacokinetics include distribution, which includes factors like rate of blood flow, hydration status and blood volume, and protein binding. Protein binding is affected by things like pKa, partition coefficient, molecular size, whether or not it's fat soluble or water soluble, and body composition. So newborns are mostly water and have very little protein or fat, which means that polar drugs will have an increased volume of distribution. Further, this means that this will end up in decreased drug NP concentrations compared to adults. Other factors include membrane permeability, tissue barriers to penetration, and concentration gradients. Excuse me. There's also age-related parameters that can be seen here in the chart, which is taken from Dr. Steinberg's lecture. And there's organ maturation changes that affect PK, like with the kidney, where when they're younger, there are more nephrons and increased GFR, and they have a peak mass between 3 to 5 years old. And so the Cockcroft-Gault equation really can't be used with confidence in children. Instead, alternatives include like the Schwartz equation, which tends to be an overestimate of creatinine clearance, Mattman, Zappitelli, or Steinberg models. And with the liver, the maturation of CYP450 enzymes differ and have peak efficacy between 2 to 5 years old. So that means they tend to have a higher metabolism and may thus have lower concentration of drugs that are metabolized by CYP450 enzymes. Clinical conditions in pediatrics can also affect their pharmacokinetics, including therapeutic hypothermia, extracorporeal membrane oxygenation, HIV positive, sepsis, burns, etc. And finally, I'll go over geriatric pharmacokinetics, which is adapted from Dr. Patrick Devon's lecture from fall 2019. So these are the principles of drug dosing in older adults. It should be noted that there's a list called Beer's criteria, which is evidence-based recommendations on the use of drugs in patients aged 65 years and older by the American Geriatric Society. However, each patient factor should be taken into consideration when determining whether or not to initiate a drug. So the first factor is to start low and go slow. Low doses may even significantly change the volume of distribution, protein binding, and pharmacodynamics and pharmacokinetics in older adults. You'll want to calculate, evaluate, and see the whole person, include factors like frailty, memory, and function. And finally, you want to set goals and monitor frequently. So now to kind of go into the different pharmacokinetic parameters. So for absorption, there tends to be no significant impact on passive absorption, but there has been seen slightly less absorption for drugs that are actively transported. Geriatric patients may also have some physiologic changes that impact absorption, including increased gastric pH, decreased gastric emptying, as well as increased blood flow and GI motility. Some drugs that are actively transported include vitamins and minerals, but however, there's not enough evidence to increase the doses of these drugs. However, what's important to note is that there's significantly different transdermal absorption as a result in changes in skin integrity, where they tend to have thinner and changed fat distribution, which may prevent the ability to put patches on, and will thus result in decreased absorption of the drug. For distribution in elderly patients, there tends to be increased body fat as well as decreased lean muscle mass and total body water. Therefore, there is an increased volume of distribution and half-life of lipophilic drugs like CNS medications and increased plasma concentrations of hydrophilic drugs. As we age, we keep the same weight, but the amount of fat increases. An example of this change in distribution is with alcohol. Alcohol is hydrophilic, so since they have less total body water, there will be a pronounced effect on alcohol in older adults. Next, to discuss protein binding. As we age, albumin tends to decrease. For highly albumin-bound and acidic drugs, it results in more active drug, which can cause toxicities. This may occur with drugs like ibuprofen, warfarin, phenytoin, and thorfin. Alpha-1 glycoprotein actually tends to increase with age and acute illness, which results in decreased diffraction and brown of lipophilic and basic drugs. For metabolism, it tends to just overall decrease due to decreased liver mass and volume, as well as decreased hepatic blood flow with age and comorbidities. This results in altered CYP450 activity, and mainly it's phase 1 metabolism versus phase 2, as phase 2 is not really affected by age. And the different enzyme effects can be seen here in the table on the bottom of this slide. Other factors to consider in metabolism include genetics, social history, diet, gender, comorbidities, and drug-drug interactions. And finally, for geriatric elimination, as we age, the GFR tends to decrease due to decreased kidney mass, the number of sides of nephrons. The GFR might decrease as much as 50%. Other factors include disease and drug-related toxicities. Calculation of renal function is often done with the MDRD instead of the Cockcroft-Gault equation, as the Cockcroft-Gault may not be good as older patients tend to have less serum creatinine to begin with, since they do have less muscle mass. And that concludes this video. Thank you so much for watching.